So, okay, we're recording. To everyone here with us, it's a true privilege to introduce Dr. Henry Brem, neurosurgeon, scientist, mentor, and father of three. For over 4 decades at Johns Hopkins, Dr. Brem has led some of the most important advances in brain tumor treatment, including the development of the glial wafer and pioneering image-guided neurosurgery. As chair of neurosurgery for 25 years, he helped shape the world-class department and generation of neurosurgeons, many of whom now lead programs across the globe. Please join us in welcoming a true leader in medicine and a remarkable human being, Dr. Henry Brem.
Thank you.
Doctor, as the first question, I would like to ask you about how things were before Dr. Brem's era. When you first entered neurosurgery, many of the tools, treatments, and research culture we now take for granted simply didn't exist. How do you see the progress we made in the past decades, and what are your feelings for the future?
Well, the change has been remarkable, of course, as you point out, and it's easy to reminisce and say what it was like, when I was a medical student in 1978, where CT was just being introduced, and there was no MR, um, and the microscope was being used in a few centers. It was being used at Hopkins and a few other places. And so there's so many things that have revolutionized over time. But I think that's one of the beautiful things about neurosurgery, about medicine in general, but certainly in our field, is that there has been such enormous progress. There's an enormous, enormous need for more progress. And so while we can pat ourselves on the back that things have changed and improved so much, we fundamentally still are not curing most of the problems that people come to us for. And so there's so much of a need for your generation to find ways to build on the shoulders of what we've done and to do better and to really, really do better. And I think that's what makes medicine and neurosurgery so exciting, is that you both practice at the highest level of the art, but also you can see so many ways that in so many different ways, whether it's research, laboratory research, or just clinical outcomes or epidemiology. There's so many ways to do better than we do, and I think that's almost an obligation as a physician, to not just practice, but to try to elevate the practice.
Thank you.
So I guess a follow-up question in that would be in reference to your CNS honored guest lecture. You mentioned how the single word that resonated with you the most was impact. And I guess with how do you define impact now after 4 decades of experience? How has that definition changed in how you approach uh, the field?
Yeah, I think that's thank you, and thank you for referencing. That was a very special moment, that lecture. Were you there for that, or you read about it in the journal?
Yeah, both.
So a lot of thought went into that particular talk, because it really it was a time to pause and sort of think about how I had gotten to where I was and where the field is going and what's important to sort of pass on. I think that I've always, what I do think is very important for the medical students and residents, and really everybody at every stage of their careers and lives, is to pause and think about what you're doing and why you're doing it and how you're doing it. Um, and one of the words that you're right, that is, are you having the maximum impact? I've never been competitive with anybody else about trying to be better than anybody else, or work that somebody's better than me. In fact, I've always tried very hard to surround myself by people who I know are better than me in so many different ways. And I think that's a very exciting environment to be in. But the person that I do compete with or worry about is me. And I question, am I doing the best that I can do? And am I doing what I should be doing? And you know, if you go into medicine, you go into surgery and neurosurgery, the first thing is, you know, we have such an enormous impact on people's lives. I mean, they come to us at what is one of the most critical moments of their life. It's one of the worst moments of their life, and it's also a turning point in their life. And they expect us to really get them through it and help them. And so, in that sense, the field was very attractive to me when I was a medical student. I want to, if I'm going to do something, I'm going to work the same number of hours no matter what I'm doing. I want to do something that really helps people get through, you know, very important aspects of their life. But I think it's also very important that you sort of look at yourself and say, are you doing the best for each patient? Are you having the right impact? Could somebody do better? Is there something you don't know that would help that patient and you're not doing it? Or do you not know how to do things? Because that's why you train, is to learn how to do things. And are you either learning it yourself or arranging for the patient to get the best possible care? So in that sense, the impact is very important on the people that you're taking care of. But then there's also the impact on if you're going to do research, for example, the question I always ask in the laboratory is if the experiment works, what difference will it make? How will that change people's lives? And particularly as neurosurgeons, if we're spending time doing research or working in a laboratory, it's not, you know, it's not the arts. It's not just because it's beautiful or interesting. It's because we're trying to do something that makes the world better and makes people's health better. So the question I always ask in the lab is, let's say you're right, let's say it works. How will that translate into something that makes people better, that changes the way we treat people, rather than just be of interest? And then it goes, I know you know that when I talk about impact is what about the impact that you have on your parents, your siblings, your friends, your children if you're married, or your spouse, or your, you know, significant other, and that's enormous. And partially, you know, as I've progressed in my career, you can't do everything. So I've learned over time that there are things that I need to let go of, so that because other people can do them, and it doesn't lessen the impact. And certainly as I, you know, moved on to being, you know, as a resident, you move on to more senior, but as, you know, certainly as you progress and I became a chairman, there are a lot of things that I said, well, other people are capable of doing things that I love doing and I was doing, but they can do it as well or better, or maybe almost as well, but it's good enough. And I need to focus on things that I think I can have more of an impact on. And that leads to family. You know, in family, you're irreplaceable, whether it's to your parents or, you know, other members of your family, or certainly if you have children. And you can say work is very important, which of course it is. But if you neglect what you need to do as a parent or as a family to your parents, your own parents, um, nobody else can do that. There's nobody who can substitute for you. There can't be a different father or mother for your children. It's your job. So I think it gets into that, you know, word that none of us achieve, which is balance, is how do you sort of make that all work? Um, and I think it's a matter of just sort of focusing on what you're doing and putting your whole head into it and your whole heart into it. If you're with family, be with family. Don't be talking about yourself. Don't be focused on the problems that you had in the hospital that day, or how much pressure you feel to study or to do other things. Just zero in on the people that you're with and make it your impact on them. When you're working, don't worry about what you're not doing, you know, and what you're giving up, the fear of missing out on things, FOMO, right? Don't let that guide you, because what you're doing is important and valuable. So I think that, you know, you need to pick what you focus on, and then you need to shift gears. And I think one of the things of success is being able to compartmentalize. And I think that if people can't compartmentalize, this isn't a good lifestyle for them, because you know, you go from the most intense experiences in the operating room. I see all of you have that background of the middle of an operation. You've got to be able to stop and be a normal human being with other people. You've got to stop and, you know, if you have children, you have to focus on what a third grader is interested in, not on how your case went that day. And And if you switch gears to doing research, you've got to focus on those problems. And, you've just got to be able to stop, move to the next thing and next thing, and then you can get a lot done. The other thing is you can't do everything at once. And so, if you look at, article about, my life experience, you say, wow, you did this, that, and the other thing, but it's not all at once. It's years of developing one aspect and years of developing other aspects. During my residency, I did zero research. It was totally focused on mastering neurosurgery, learning or surviving in neurosurgery, should probably be more realistic, and passing my boards and, getting through what I needed to do. And then later on, the research became a big focus, as well as having a big practice. And raising my children was a very critical time. So I think you constantly relook and say, what's best? What can you do best? Not looking over your shoulder what other people are doing, but what are you doing best? And you do need to look short term and long term. I mean, some of it's not fun or easy today, but it's taking you to a place that you want to be at. And so you work hard for it now.
Thank you, sir.
Dr. Brem, I think that's really interesting. And I think it's a good point that you bring up because while it's easy right now as we're progressing towards residency, it's really easy to just focus on our work and just focus on research or school. But sometimes I think we can forget that we have to leave room to compartmentalize the other aspects of our life that will become a lot more prevalent when we get into the working force, right?
No,
But
I
I
would,
wanted to,
you're in the working force. It's just at different
all right,
stages to do different things.
I'll take it, a different stage of the working force. Um, something that you had talked about that I thought was interesting. You're talking about a huge impact that you have on patients' lives. And I know that in the past you've talked a little bit about, having the trust of these patients. And you mentioned a little bit how, there's like a moral obligation with that. And that kind of helped you to pursue more research after you, like you said, you survived neurosurgery and mastered it. And I was wondering, a lot of people who watch these webinars are, they're incoming physicians, young physicians. What or how can these young physicians build emotional resilience to be able to master the technical, but also the ethical way of having that obligation and, putting the patient's lives in your hands and they're fully trusting you?
So, I mean, it's a major point. I don't have easy answers for that, and everybody deals with it differently. Um, I think that you don't. I said it, so I'm contradicting myself now. You don't master neurosurgery. It's a lifetime of developing and knowing your limitations both. I mean, it's very important not to be macho as a neurosurgeon, and on the other hand, you have to be bold and you have to do what you have to do. The question is, when things don't go well, it's very important to analyze, is it because we don't know how to treat a glioblastoma, which is true. I mean, we can help people and we get them through, but at the end of the day, it's a fatal disease. Or is it that you don't know how to treat a glioblastoma because you couldn't do the operation safely, or you made a mistake, or something didn't go well? And if it's you, and then you need to fix that. Nobody's perfect, and we do make mistakes as physicians, as surgeons, as neurosurgeons, and you can't not function after that. You have to say, I need to do better. You want to avoid those moments in your life, but we all have them. And then when you're dealing with things that are just miserably hard, many of the residents, for example, when they're on call a lot and they're second year, third year neurosurgery residents, they start to get very dark about how many car accidents they've seen, how many gunshot wounds they've seen, and they start to see that all these people, young people come in and they're dead, they're brain dead, they're shot, they're fall, all these accidents, and they just say we're not helping them, and and it can get dark, and you can say, maybe I shouldn't be doing this. Maybe this is not a good way to spend my life. And that's, unfortunately, that's more of a training issue than later on, because, the residents rarely come to clinic with me. They rarely see all the grateful patients. They don't see the patients that we operate on around the day, and come back and they say, well, God, you took out my benign brain tumor, let's say, or malignant brain tumor, and I'm living life, and grateful. They see the people that are sick and in the hospital and are staying there for a month because they have complications and problems. And so you get a skewed view, I think, a little bit of what we do. To me, as in that paper, I described the different stages that, when I first started finishing my residency, during my residency, I just tried to, make sure I was doing the right things. I knew how to walk in an operating room. I knew what to do. And, I knew that there was always someone backing me up. And I knew that I was just trying to, learn what I needed to learn, so I wasn't embarrassed, and I could do, what was expected of me. It's actually it's pressure, and it's hard, and you work very, very hard, but it's pretty systematic. Nobody was expecting me to do what I didn't know how to do. It was a matter of, you got to learn and study and practice and get better at it. When you're on your own, or when you finish, it starts to be, are you doing, or did you learn it? Are you able to do it without somebody right over your shoulder looking over? And that's a lot of pressure. And what I found is that there was a tremendous sense of relief that, yeah, I could do all the things I was taught to do. And the other things to talk about the impact on families and patients. And I felt very close with, and I got close. I think that's very important to do for me, to be close with patients and their families, and to help the human being that has a neurosurgical problem. And then it was very disappointing that, as much as I wanted them to do well, and as much as they trusted me to do well, that, let's say with a glioblastoma, which is, a major part of my life, that the person's still going to die in a year or two. So you say, well, is it useless? Is it, what's the point? Or, so what I've learned is two things. One is that the care that I gave those people is very valuable to them, even if the outcome is bad, even if they don't survive. When I see those people and their families years later, they're grateful. They just say, it was a terrible time of our life. It was very hard. You made it better. You were always there for us. You always answered our calls. You always, calmed us down. You always showed us some optimism and said, you're going to make it work, and you're going to, if they're uncomfortable, you'll treat them, and you take good care of them from the beginning to the end. Not every surgeon does that. Okay, but I would say every good surgeon does that. The other thing is, to me, it said we got to do better, and I was blessed with opportunities that that I had. It's funny how that all evolves, right? Many of you work in laboratories so you'll get into medical school, or you work in laboratories so you'll get a good residency, or you work in, so I did that. We all did that. I said, gee, if I want to get into a medical school or a good medical school, what can I do? It's research. I can't operate on people. I can't do, other things, but I could do research, and I could be good at it. And then that'll help me get to the next level. And so I was fortunate that I, either had or made opportunities. I worked very hard for those opportunities, and I contributed to those labs that I worked in, and and that helped me, and it advanced me. I got to a great medical school, and I got great residency and all those things. And then when I came to Hopkins after I finished my residency, I asked them that, I wanted a lab because I knew I had a good track record in the lab, and I knew all the cliches that, it's good for, it advances the field and all this kind of stuff. And I looked at it almost frankly as a hobby. I just felt I'm good at research. I've done it for a while. I know it's fun. It's exciting. You're seeing nature in a way that nobody else has ever seen it. Every experiment is something, a new aspect of nature that's amazing. And yeah, it could have an impact, and that would be a good thing. But mainly, it's some people like to play golf, some people like to have other sports. I like research. It's a fun place to be, and that's how I really came into Hopkins. sort of thinking like, I know the game, I know I can do it, and I'll see. Now, I went in there with the attitude is that I would give it 5 years once I finished my residency, and I would reassess. I would do that hard assessment about impact and about what I'm really doing. And the 5 years was because I think you can't do that after a year or two because, that's not giving it a fair chance. I said, I'm going to give it my best for the first couple of years and then reassess. And it was also my wife was doing her residency in radiology. In 5 years, she'd be done. And I said, in 5 years, I'm going to see, should I be an academic? Should I be in private practice? Should I be at Hopkins? Should I be someplace else? And I was very open to going to private practice. If that's it, because I love neurosurgery, and I said if I could practice at a better level in a pure practice, I would do that. There wasn't a rigid line of, gee, I want to be the Cushing professor and the chairman and all this stuff. That never was my motivation. None of this is about advancing academically or position wise. It was just about what was the best at that time. And in 5 years, I looked at it. There was a transformation after about 2, 3 years. Beginning, by the way, I did 95% clinical work, and I built up a practice very quickly and a reputation very quickly that I would take on, very difficult cases, and I would take, really good care of them. And compassionate care and skilled care, and I was always there for the patients. And word spread very quickly that I would take care of it. And it was spine, and it was tumors, and it was vascular. It was a big range of things. And then at some point, actually, in my second year, one of the other faculty members was standing by my desk, Jim Campbell, and he was holding my CV, and I was really proud of my CV because as a medical student, I published in Science and Journal of Experimental Medicine. I'd done all these, very cool things. I'd been very accomplished in research, and I was looking for a compliment when he was looking at my CV because everybody complimented me on my CV. And I said, "What do you think, Jim?" And he said, "I think it's a tragedy." And I said, "My CV's a tragedy?" And he said, "Yeah, yeah." He said, "Because you have so much talent in research." And he said, "What you're doing, you could be doing at a community hospital." He said, "You're taking great care of all of that stuff, but you don't need to be at Johns Hopkins to do that." He said that with the potential you came in, what are you actually doing with all of that? And it really shook me up. And I said, "Well, I don't have time. I just working all day and night all the time on my practice." And he said, "Make the time if it's important to you." And what I did at that point, everybody has a different formula. But what I wound up doing is I wound up signing out for a month. Um, and to Ben Carson, actually, who is, sort of a partner of mine at that time. We both started at the same time, and he was doing adult neurosurgery at the time. Fantastic surgeon, fantastic physician. And I said to myself, I knew Ben very well. I said, I'll sign out to him for a month. I probably won't have a practice after when I come back in a month because everybody's going to love him, which they did. And he's going to take great care of them and they'll stop sending patients to me. But I do have to fulfill my potential. I do have to see if I can, really make it work. So for a month, I worked on a grant, a major grant, and two grants actually. And I really worked day and night. And actually, my kids would say that when they heard that I was working on an NIH grant, that was worse to them than anything I did clinically. That if I was working clinically, I'd come home. I might be late, I might miss something, but I was home every night and stuff. When I was working on a grant, I was like day after day, night after night. I would just, there was no endpoints. I just was totally immersed, and I hated that. But it was finite. So I signed out for a month and really put my research ideas down on paper and plans down. One grant got funded with a great score. Another grant got a terrible score. That's a different story. And, how you react to that. What do you do about that? Eventually I came back and back and back and made it work. But when I came back to my practice, which I thought probably wouldn't exist anymore, I found that actually people were willing to wait for me, and that a lot of the referring docs said, "That's fine. He'll be back in 3 weeks. Well, could he see the patient in 3 weeks?" And so when I got back, I was immersed in clinical work until I got the scores back, and we actually did the things that we needed to do. And it was sort of that balance. But it was a jump start, and it wasn't my second year. It wasn't even in my first year that I did that. And then at some point, I realized it wasn't a game anymore, that I realized that a lot of people, a lot of students and others were really depending on me to be successful with the research because they were putting their lives in my hands as students and as residents to do the research and get results and have an impact. And also that we might really, it might be the real thing. We might really change the outcomes for people with brain tumors. And that it wasn't just platitudes, but it was real. And then I began dividing time in a different kind of way. And I started putting a lot of effort. Eventually, we ran multi-institutional clinical trials at 27 medical centers. And I did a lot of traveling and I did a lot of, you know, preaching, a lot of going to people and convincing them that this is worth trying. This is a good idea and so on and so forth, and then goes down that journey as to each different stage there were different obstacles, and you face those obstacles. You say, is it worth it? Is it not worth it? Should I be doing it or should somebody else be doing it? And I don't think you make any progress. I think if you look at every idea, every change in society, look at all the big things. Look at, I'm talking to you from an Apple computer. It was Steve Jobs. I drive a Tesla, and whether you like him or not, we're driving, electric cars because of Elon Musk. And I think that, my colleague Bob Langer, who's a professor of chemical engineering at MIT, there's so many, and we have his technology, one of his, 1,000 patents is on the technology for the coronavirus vaccine from it. He was one of the founders of Moderna. He also had the patent on gliadel, the polymer that we used for brain tumor therapy. I mean, he's saved millions of lives as a PhD, as a scientist. So he, my impact is trivial compared to what Bob Langer has done. But it's taking those things and championing them and doing everything that it takes to make them successful. And again, not all at once, because then you can't do other things, but at different stages. And with all of that, keeping a very, close eye on my family and making sure that I wasn't getting so consumed that I couldn't do the right things there. And there are a lot of tricks and things with that too. I was doing a lot of traveling. So at one point when my kids were a little bit older, when they were like 6 years old, 8, 9 years old, I have twins. Um, and a daughter was 3 years older than them. So the twins were never separated. I mean, they're always together, they're in class together and activities together. So when I saw, gee, I'm doing a lot of traveling, that's bad for the family because I'm flying all these places and I'm gone. So I said, I started this thing, that'll take one kid with me on every trip that I could. I mean, sometimes it wasn't possible, but to Europe, to the West Coast, to Alabama, to California, to Florida, I would take one shot that would be one-on-one time. And 95% of the time was just us. And then 5% I'd give a lecture or I'd meet with people and, they'd color in the background or do something. Those turned like the burden of travel and what it was to like the greatest memories. They all talk about those trips as being very, very precious. And then the ones who were home also they had more time with my wife. My wife, by the way, is professor of radiology and is one of the leading experts on breast cancer and, has had enormous impact. And somehow we've been able to, I don't want to say balance because you never really get balance, but been able to make it work and be happy with it, not burned out or exhilarated, the opposite of burned out. Now we have not only are, you mentioned 3 kids, I have 3 son-in-laws, and I have 10 grandchildren all in our area here, and they're, that's a big part of life as well. So I don't look back and have any regrets. I look, things have been very, very good. And when I know the theme here is a little bit about leadership. People ask, how do you become the chairman of, neurosurgery at Hopkins or something like that? Never my goal. Never, never. I did it when I thought it was necessary to do it, which was 26 years ago, because I thought our culture could change when Dr. Long stepped down, if the wrong person took the job. And I felt that I had achieved enough that I owed it to other people, to the younger people, that I kept that environment going and enhanced it. And, hopefully I've done all of that. But that wasn't my life goal. My life goal was to do good, just to, make the world better through neurosurgery and through taking good care of people and respectful of people, and then helping younger people, fulfill their careers. Carlotta, Alex Levy came to me when he was a fellow, and he came to work in the lab, and he actually brought his then 6-year-old daughter with him on that trip. So he didn't learn that from me. He's always been a great person, a great father, and he said, "Would I mind if he didn't know what to do with his daughter because he was coming from Italy for the interview for the meeting with me?" And I said, "Oh my gosh, bring her in." And I said, I opened up the drawer. I said, "I have crayons here and color because my kids would come." And he said that's what sold him that he was gonna, and we spent that led to 27 years of friendship and working together. And eventually he became professor at Hopkins, and eventually he went back to Italy to be the chairman at the Gemelli Hospital. So I think it's day by day that's doing what's fun, what's good, what makes sense, and trying to help people and do the right things.
Thank you so much, Professor, for this. I completely agree with everything. I personally have like 6 cousins, and like my aunt is a cinematic director, and he also do the same. Like he every time he travel in a different place, he always like take pick one of them and just like do something with them. And I think this is really important, just to give them the importance that they really need. Um, Coming back to like your research, I have a question. So, in the early phase of polymer development for drug delivery, um, you face not just technical challenges but persistent skepticism from peers. And I read that you described the recurring phrase was "it will never work." But you didn't respond. Instead, you just return to the lab and generate data and publish and address objections point by point. So, how do you cultivate like this mindset of resilience, not only the scientific persistence, but also the psychological stability to remain visionary without becoming discouraged? And also, how can young physicians like us develop this same clarity of purpose in the face of institutional or cultural resistance?
No, you're asking a lot of things. Thank you. Um, you mentioned for one thing is it's a dangerous issue because you mentioned persistence, and persistence is the formula for success. But my mentor, Dr. Folkman, used to say there's a thin line between persistence and obstinance. You need to be careful. If you're being criticized, they may be right. And and so if for example your bosses, whoever that may be, are constantly telling you that you need to do something in a different way, you can be persistent and keep doing it your way and get fired, or not be doing it as well as you could because you're not listening to them, and they may be right. So you need to evaluate. I think the point of the criticism was that we didn't we tried very hard not to get discouraged, but to say, are they right or are they wrong? And how do we prove that we're right and they're wrong? Or how do we prove, what is the basis of the criticism? Is it valid or not? Now, some criticism is just, offensive. It's just foolish. And you just say, well, I'll tell you an example of that. Our first paper that we sent in with polymers, and so we'd given so much thought, we'd worked it so much with the engineers, with all our colleagues, and wrote a paper, probably with Rafael Tamargo, on the model that we showed that if you gave BCNU, the same drug, with a polymer directly in the brain, the same drug given systemically, we got a much better survival with the putting it in the brain. And we showed that very nicely in an animal model. And we said that the polymer we were using was biodegradable and that it would disappear in about 2 weeks. And the paper was rejected from the Journal of Neurosurgery. And the reviewer wrote, "What a stupid idea. Like, why would anybody they're proposing that every 2 weeks they would reoperate on patients with gliomas to keep putting these wafers in, and that no patients are going to agree to have an operation every 2 weeks to keep getting treated. And I looked at that and I said, on the one hand, you can get angry, you can say like they missed the point totally. Secondly, you say like, how stupid is that? Like, of course, that isn't what we were proposing. And then what I said is, we really screwed up because how could anybody read our paper and not understand that that isn't what we were saying at all? I said, we were not clear enough of what we were trying to say. Now, it was at that time a totally new idea. Nobody was talking about that. And now, obviously, and to you, it's always been part of what neurosurgery is. I mean, it's a given. But at that time, nobody was thinking like that. But still, I said that that's our shortcoming that we didn't write it better in the paper. So we went to another journal, we wrote it. We didn't do anything differently for that because it was just a ridiculous argument. But we said we need to simplify what we were saying and make sure that people understood. Other times he said, well, let's say, are they right? Are they not right? And frequently, since we were talking about science, and a lot of the arguments, early on were science, we said, so you can answer the questions, go back and answer the questions and show the data that, they're correct or not correct, or modify the system so that you fix what people are criticizing. And that's what we did over many years. And I think that's how you get success. I think that neurosurgeons can be very thin-skinned. And if you're thin-skinned, you don't make progress because anytime you do something new, um, people object to it. I drive a Tesla. People, that's crazy. How are you going to get electric cars? You're going to run out of electricity. You can't get a gas station. It's whatever. There are arguments, and either they're right or wrong. But people don't change unless they're convinced to change, that it's better, that something is superior. So it takes time to change, particularly in science. The whole basis of science is reproducibility. So if I say I have something that's different than what other people are saying, it's new, they have to be able to take it to their laboratories or clinical to the operating room and see if it works in their hands. And there have been lots of things we've done like that. And so we're talking about gliadel. What about navigation? I mean, you guys don't think twice about navigation. We didn't have navigation. We didn't, when I started, we hardly had CT. I mean, if you look back in a paper from the 1980s when I was a resident, and you look at the CT, they're like a blurry picture, which, a little bit of like increased dots in one place. Say, well, that's where the tumor or the blood clot is. Nothing like what we see today. But we certainly didn't have navigation. And when I started working with the radiologists and the engineers who were developing navigation, my chairman came in the operating room. I was using it, and we'd take an extra hour or two of operating time to use, to set up, to put the fiducials on, get it all. We'd take an extra hour at least to set it up, and then we would show that it worked, it didn't work, and we did studies on the accuracy and, and how to make it work. It didn't work for the posterior fossa, it only worked above. Eventually, of course, it works for everything. But I remember Dr. Long came in and we said, real surgeons don't need computers to find tumors. And then he walked out of the room and I said, ouch, that's, I was doing it on a lot of tumors that of course, were right. I knew exactly where they were. They're right on the surface, but it was validating the technology. And I spent an enormous amount of time in my residency, which you guys will never do, of takebacks because people missed the tumors. I mean, none of our residents have ever seen that, but that was common in my residency. Take someone with a brain met, take them in the operating room, do 10 passes, not find a tumor, wake them up, sew it back up together, take them down, get a CT scan, and the next day bring them back and say, oh, we were going this way, we should have gone this way, and then take out the tumor. I mean, you'll never see that because of navigation. So it was very important to do. But yeah, there was skepticism. in the place I was developing it with the people who were supporting it, there was skepticism. You're always going to encounter that if you make change, but that's a sort of so what.
Thanks, Dr. Brem. And as a final question before the Q&As, I'd like to ask you, you've once said that one of your greatest satisfactions has come from mentoring the next generation, not just to master neurosurgery itself, but to move forward.
Yes.
And in your experience, what qualities make a mentee truly stand out, and how can a young physician like us not only earn that kind of mentorship, but sustain it over time?
Yes. So I thank you for, you know that that's very important to me, and I've spoken about that and written about that. I think a couple things. Number one is some people say, "Oh yeah, I was very fortunate. I had great mentors, and that made me successful." And that's true. I'm very grateful to the, long list of people who really are responsible for mentoring me. But I really feel very strongly that mentorship is a two-way street, and I think that's what you need to remember. So in mentorship is not cloning. It's not like, well, gee, I like Henry Brem. I want to be exactly like Henry Brem. That's not what it's about, because A, that's boring. B, it's not possible. No two people are alike. And you don't want to emulate everything about any other person, because people have good qualities and have bad qualities. You want to emulate the good qualities and, and learn from the good things. I look at mentorship as somebody who does something better than me. They know how to do something better than I know how to do it. And whether that's being a surgeon or being a surgeon scientist or being a parent or being, I look at people and I say, gee, so what I would say is when I see somebody who has success, if you will, in a way that I don't, whether that's in science or medicine or life in any aspect, I say, gee, can I be their mentee? Can I learn from them? Can I, and that's to today. I look at that. And but just doing it, it's not a one-way street. I think number one, you have to have an interest. You have to seek out the people. You have to think about what it is you're trying to gain from them. Um, and then you have to bring value to them. You have to do it in a way that you make yourself valuable so that you really can soak up what they have to give. So if somebody wants to work in our laboratory, for example, they can't just say, gee, I want to come to your lab meeting and, or I want to meet with you for an hour a week and, be a great scientist. What they need to do is they need to work and they need to bring, they need to they need to bring ideas to the table. They need to talk to me about ideas. They need to show me data. They need to advance my career in a way. Okay. But not in a way, in a big way, because so much of what we've done is based on brilliant, young people that I've been surrounded with. And then, yeah, when they do that, they start saying, I'd say, oh, I'll go this direction, that direction, pursue this further. And they learn. And also, then it's after hours and it's long hours and it's, we spend time together. Just saying, gee, how do you be successful doesn't, no, or now the big thing is people ask, can I do an observership? And I say no to that most of the time. I love mentees. Observing me, like number one, I think it's boring. Number one, most of the things I do as chairman are not things that you want to learn unless you're on the verge of being a chairman. But and then it goes to surgery. It's the same thing. If somebody is going to operate with me, do they review the case in advance? Do they read up on the case? Do they call me the day before and say, can we go over what the approach we're going to take? Do we, are they prepared? Or have they studied the anatomy? If so, you know, it they learn a lot. They learn the subtle things. If they come to the operating room prepared and skilled at the basic things, then they're going to learn the fine points. They're going to learn what is it that makes a difference. If not, and they're going to get to operate more, if you're a resident, if you're prepared. So I think everything about being a mentee is A, figuring out what you're looking for, what you want, and B, um, giving value to the person that you want to be mentored by. And by the way, that's probably true of every relationship. It's probably true of a boyfriend-girlfriend relationship or spouses or everything else. If you want to be, a great husband, a great wife, then be a great the other thing to that person, or a great girlfriend or boyfriend. It's a matter of what you give, I think, is how you get the most from other people. You get the most from other people if you're giving the most to other people. And so I think mentorship is just a big part of life, but it's a matter of recognizing that other people have something to offer you and putting yourself in a position that you're helping them. And then you really, really learn what makes them tick.
That's great. Thank you. Okay, so we have one question here. Sina asks you, what are your predictions for the future of neuro-oncology in terms of diagnosis and treatment?
It's interesting. You asked earlier on, you said, you look at the way neuro-oncology or neurosurgery was when I started versus the way it is today, and how many advances we've made. And I think we've made advances, and there's a long way to go. Okay. I mean, there's so much, I wouldn't pat ourselves on the back. I think that we need to do so much more. But it's interesting that when I started at the National Neurosurgery meetings, the brain tumor sections would have, there'd be about 10 speakers, and there'd be about 15 people in the audience, because it would be the speakers and their boy or girlfriends or spouses, be with them. Nobody else. There's very little interest in advances in brain tumor therapy in the 1980s. Today, those meetings are packed. There are hundreds of people. And today, there's tons of being published. There's the Society of Neuro-Oncology didn't exist. That's a huge meeting with, 1,000 people at it. There are people who are really studying every aspect, from the genes to the liquid biopsies to treatment delivery to focused ultrasound to new modalities, diagnostic, therapeutic. So I think we're going to see tremendous advances, tremendous advances. I think that neuro-oncology is going to look very different in 5 years than in 10 years and in 20 years than it does today, and we'll do much better. Already we have targeted therapies without chemotherapy or radiation or surgery that can melt certain tumors away, because we understand what genes are expressed. IDH1 inhibitors has been a great advance, but a subpopulation of tumors. I think that with your generation and with the interest now in finding better ways, it's going to pay off. 90% of it won't, but 10% will change the field. And so I think it'll get better. How that's going to look, I don't think somebody would have predicted what it looks like now 20 years ago. I think that it's going to be different. It's going to be better, and it's going to be different. And in ways that we can't even conceive of right now, because smart people are working very hard with new ideas. The other thing is, every generation goes on the shoulders of the previous ones. So somebody comes into my faculty. I mean, this has been true over the last 25 years. I've been successful. Okay. I'm a good surgeon and a good researcher. And I say, gee, Henry Brem accomplished a lot. Well, the guys who come in, they don't really want to do exactly what I do, because it's going to be hard. They're going to get compared to me all the time. And they're going to say, well, he did all of it. He's better. So why would we send a patient to you when we have him there? So what people do is they carve out a different area and a different approach, and then they develop it, and they become the world's expert in it. So give you an example is I used to do all the pituitaries in Baltimore, in Maryland. I did 90% of the pituitary surgery through a microscopic, like Jules Hardy and like Cal Post and other people that trained me, and like Dr. Long did before me. But I did, for the state of Maryland, I did almost all the pituitaries. Then Gary Gallio was one of our residents. I said, gee, endoscopic approaches are gaining favor. And I said, we had played with it and it didn't add anything. I was skeptical. Like Carlotti asked about criticism. I said, the people who were talking about that are just making false claims, because nobody's better than me. I do such a good job. And so Gary asked if, after he finished his residency, if he could go do a fellowship for 6 months to Charlie Teo in Australia, far away. But Charlie Teo was reporting crazy, wild stuff of just doing very radical operations through the nose endoscopically, and he was doing things that nobody else could do. And I said, sure, go for it. And we got funding, and he went. And he came back, and he was very respectful, and he said, Brem, you're the best. You keep doing what you're doing. And I said, yeah, you do it, do these new techniques. And I said, let's compare notes, because I think what I'm doing is best. And so he did endoscopic, pituitaries, and I continued doing what I thought was the state of the art, doing it that way. And I looked at his results and I said, we're getting decompressions. That was the field. It was, decompressions were great. I mean, women who were amenorrhea, galactorrhea, and amenorrhea, they started having periods, they had kids, very satisfying. People came in, with pituitary apoplexy, uh, blind, they regained their vision. I mean, pituitaries were the most satisfying part of my practice. And a lot of people with adenomas, you decompress the chiasm, they got their vision back. They're very happy. Some of them you need to radiate, which of course then led to panhypopit and, longer term complications. But they were happy. We did the job. We were doing state of the art good stuff and avoiding complications. And look what Gary was doing, and he was getting cures. We never got cures by surgery alone. He was working around the tumor, and he was doing it, and he was taking 16 hours to do it. It was pretty painful. But there was clearly a better way of doing that operation than the way we were doing it. And I've looked at that and I said, I've got two choices. Either I have to train and learn how to do that, or I should just realize that it's better the way Gary is doing it. And that's what, because I'm a little lazy. And I just at that stage of my career, I don't want to train and do that. I had too much else on my plate. And I said, Gary, you need to take over the pituitary service. And I took the most delicious part of my practice, the best part, and I turned it completely over to him. I told patients they need to see him. And then he developed, and he's one of the best in the world. And now we have 3 people who do full-time endoscopic skull base, and you'll all get trained in that. That's the way, that's the standard. But it's a matter of recognizing that. So what did Gary do? He didn't say, well, I'm going to get a different gliadel. He could have. He's a brilliant scientist. He said, I'm going to take some other aspect and advance it. And I'll be, I'm not going to say famous, but that'll be my thing. And everybody's doing that. Chris Jackson's doing it with skull base and acoustics. He's doing a great job because he took that niche and he's improving on it and getting better and better. And I think that's how things advance. You build on what other people do, and you don't duplicate what they do, because it's hard to do that. It's hard to be just as good as someone who's been doing it for 40 years, but you find some aspect and you do it better. And then and then that's the field. Then you're all trained in the better way of doing it. Of course, you get stubborn people, not like me, who would fight that, and then they become outdated and cantankerous, and they keep saying the old way is the only way, and that's that fighting over progress. But I think smart people realize when there's progress, and they move on to other things.
I think this is a really important aspect, and I think this is one of the reasons why Dr. Levy is so loved in our hospital, because he has this approach. Like, he's a true mentor. He loves teaching people. Instead, like, there are other doctors in Italy which are more like, I'm good. I can do that. Like, you will not be in any time in the world like better than me. And so, like, it's usually less frequent that residents take care of the patient, like completely respect than like the big professors. Instead, Professor Levy usually say to his residents, "Oh, try to do that. Like, I will start this operation, but then you have to continue. And like, I want you to do this better than me." I mean, of course, it's hard, but he has this approach, and he's considered one of the best. And this is his last year as a professor, so we are all very sad. But Yeah, I mean, I think that staying in Hopkins really give him this um, like American approach because he's one of the only one that I know that is this mentor uh, like prone approach.
No, he's remarkable, and he was loved at Hopkins. So it's funny when he left. I mean, we had a lot of discussions about his going back home, and there were pros and cons of doing it. He was worried about the risk of going into that environment, and but when he decided to do it, nurses would stop me and they'd be angry at me. They said, "Why did you let Dr. O'Leary leave?" So he is a very, very special person. He was loved at Hopkins by the residents, by the faculty, by nurses, by everybody, because he has that special magic. But I do think in it's not just Europe. Europe has a reputation of being more autocratic and some of their pyramid of just the top is the person you don't question and they do things. That's not our system, and Dr. Levy is great. I don't think you make progress with that. I think it's good for a little while because you have good people and they're at the top, hopefully. But you need to keep evolving. You need to keep changing. And that's true as medical students, as residents, as when you get out. It's a life. But that is what makes this field so special and so wonderful is that it's never boring. It's never like, well, I've been doing this for 10 years, the same way, same thing, same outcomes. You're always trying new things and we're learning more, and there's better technology and better tools, and what keeps it exciting, I think. And as far as just to end, maybe on the mentor-mentee thing, I mean, to me now, um, as I'm slowing down my clinical practice and going towards, looking at what I should be doing and looking at impact, I'm actually focusing even more back on the lab because as chairman, we kept things going, but it was, a lot of it was in autopilot. And now I look at it and I say, boy, we can change the way brain tumors are treated through that work. I think if I do another 100 operations or 1,000 operations, it's not going to make a difference because there are enough people who can do that I've trained and have trained with us and are, I'm okay with that. But I think that in research, you really make an indelible change. And the other thing is that it's surrounded by young people. There are people from Italy, from India, from all over the world that come to our laboratory, and from Brazil for sure, and Colombia, all over. We've had so many people from all over the world and people from the States. Um, and it's young, inspired people who just want to make a difference. And I think so that environment in the lab is a very, very exciting one because it's fresh and it's ideas and it's enthusiasm. And there's very little cynicism because people really want to do good things. Sometimes doctors get jaded as they get older or what you call burnout. So you don't see any of that in young people in a research environment. So to me, that's where I want to be now. I want to get that youthful excitement and just keep getting stronger with that. So I
Professor,
hope we'll see all of you. I hope I'll see all of you in the States in Baltimore.
We
it's
all
all
hope like this.
Thank you. Well,
Professor.
Lana, I hope very much that we come visit you in Rome because we miss Alex Olevi and we're open
I
for a
will
bit.
not suggest you to come here this year because it's crazy expensive with the like Jubilee. But and there are like a lot of people. But definitely in the next year, I think it's the best period. And not right now because it's too hot. Like there are 46 Celsius degree. So now definitely a good location.
Okay, I'll wait. Thank you
Okay,
very
so
much for inviting me. It's been a pleasure, really sharing ideas with you.
Thanks, Professor. We'll make sure to make the most out of it.
Thank you. Thank you. Thank you.